All right, well, let's get started. This is Dr. Neacsiu, who is an assistant professor at Duke. She's going to be telling us about neurostimulation for misophonia. Welcome.
Thank you, Sylvie. Hi, everyone. I'm so glad to be here and so proud of myself to have navigated all of this technology with Lisa's help and other organizers' help in the last hour. So my name is Andrada D Neacsiu. I'm an assistant professor at Duke. I'm also the director of the Brain Stimulation Center and the Chant Lab. And I will tell you about my research, which involves an approach to developing an intervention for misophonia that involves neurostimulation or neuromodulation. And I'm going to shift to my screen. Okay, hopefully you guys see things advancing. So for disclosures, I am a consultant for Behavioral Tech, which is a training company, and the trainings I do for them are in dialectical behavioral therapy. So somewhat relevant to some of what I'll be talking about today, but pretty different. And I have received research funding for misophonia research from the Misophonia Research Fund from the REAM Foundation, as well as support from the Duke Center for Misophonia and Emotion Regulation. Okay, to get started, I will give you the introduction to misophonia that's relevant to my talk. So I know you've heard a lot this morning about how we think about misophonia, and it sounds like a lot of the people present here probably could teach us a lot more than we already know about it. So relevant to my research is the distress that's caused by the trigger sounds for those who suffer from misophonia. And we know that there are some intense reactions to these sounds and that these reactions are difficult to manage. And what got me interested in misophonia research is the similarity between this difficulty to manage emotional reactions in misophonia from psychopathology. So my research outside of misophonia is across all sorts of disorders, mood disorders, anxiety disorders, personality disorders, how people have difficulties managing, how people with difficulties managing distress solve that problem, or how did they deal with that. And my interest was in trying to find parallels between kind of traditional difficulties managing distress and misophonia. So just a little detour into emotion regulation research to see where I'm coming from. So when I say emotion regulation, what I mean is that we all engage in some behaviors or actions or strategies to influence the emotions that we have. When we have those emotions, how we experience and express them. So if I have a frustration because my computer is out of power, I might try to jump in and problem solve that problem to feel less frustration. Or if I might have anxiety about giving a presentation, I might take some deep breaths to reduce that anxiety. All of us have emotions, and all of us try to adjust our emotions given the context that we're in. That's not different for anyone or anything. Some of the strategies that we use are things like not thinking about it, suppressing our thoughts, or trying to problem solve, just like I illustrated, or engaging in mindfulness, paying attention to our bodily sensations. We could change our thinking. That's called reappraisal. We can engage in meaningful activities to pull our mood up if we're feeling down. We could distract if we're upset about something. We could do exposure, like really sink into that emotion until it feels less intense. We could engage in exercise or do some self-soothing. Bubble baths are some of my favorite ways to manage distressing emotions about grants in particular. We could use distancing, so kind of putting some thought distance between us and whatever's upsetting to us. And sometimes we could even use substance use. So a lot of people drink or use substances because it helps them manage their emotions. And within psychopathology, we think about emotion dysregulation as deficits in the abilities, in someone's abilities to change their emotional experiences, or use of problematic strategies. So someone might not know how to reappraise. They're having a difficult emotion, and they might not know how to change their that reaction by thinking differently about it. Or they might use a problematic strategy like pushing their thoughts away. Sticking with anxiety for a second, let's say again I have anxiety about presentation. I might not know how to think differently about it and really sink into those thoughts about it's going to go terrible and awful and everyone's going to hate it. Versus reappraisal would be something like, it's going to be okay, it's going to be done, it's going to be short-lived, something like that. Or I could try to push those thoughts away of distress. And generally, that's not an effective strategy because we know that thought suppression intensifies that emotion. So here I'm going to get much more complicated very quickly, but I'll move away from this slide. We published a paper recently in the Frontiers special edition about misophonia. And the QR code down here takes you to the paper directly if you want to read it. Where what we've done is we've looked in the literature about kind of how emotion dysregulation looks in the brain across psychopathology and how it looks in the brain for misophonia for what we know so far, and what are similarities and differences. And as you can see from kind of the summary on this slide, we see some similarities between misophonia and other disorders in hypoactivation in the prefrontal cortex, which is thought to be relevant to emotion regulation. So we want our prefrontal cortex active to downregulate distress. And we see some prefrontal cortex hypoactivation, so it's not working as well. Some hyperactivation in areas like the insula. The insula is relevant to our perception of our own body and of our own sensations. So there's more of that present when there's emotion dysregulation, both across disorders and in misophonia. And then there's other areas like the amygdala or the cingulate cortex that are involved in emotion and appraisal. And those tend to have hyperactivity or hypoactivity in across disorders and in misophonia as well. So I'll move away from this, but a lot more detailed information about this is in our paper. So how do we change emotion dysregulation? Well, there's two ways. There's many ways, but there's two ways that I'll talk about. So in traditional psychopathology research, cognitive behavioral interventions are one evidence-based way to change emotion dysregulation. So how we do that is we teach people skills for how to manage their emotions, and either directly or indirectly. And we know that teaching these skills has benefits for many disorders: depression, anxiety, OCD, attention deficit hyperactivity disorder, personality disorders. So one of my questions is using emotion regulation skills a possible intervention for misophonia because of these similarities we see in the brain, in differences in the emotion regulation network. Another kind of novel approach to changing emotion regulation in psychopathology is neurostimulation. So neurostimulation is a graph here. What it is there's a coil, a figure-8 coil, that generates a magnetic field around the coil, and that magnetic field induces some electricity in the middle of the coil. And because the brain is an electric organ, that electricity that we induce activates the neurons that are right underneath the center of the coil. And we know from research that it's not just that area underneath the coil that gets activated, but all the network that's connected to that particular spot. So we can activate or inhibit an entire brain network using neurostimulation. And this is safe. It doesn't require, it's non-invasive. It doesn't require like any implanted device or putting you under or anything like that. It's something that can be done on an outpatient basis. And there are currently FDA-approved neurostimulation treatments for depression, for obsessive compulsive disorder, and for addiction, and many more are in the works for that. Another reason neurostimulation can be relevant, again, for intervention for misophonia is because we found in research that it can enhance human performance. So studies show that you can undo the effects of sleep deprivation, you can reduce cravings for substances or for food with neurostimulation, you can improve emotion regulation, you can improve surgical skill, and then you can reduce post-traumatic stress disorder much more than behavioral interventions alone when you engage the brain circuitry with neurostimulation as well. So how is this relevant to misophonia? Well, my question was, do approaches that work in changing emotions in psychopathology, can those work in misophonia as well? And what are the similarities and differences in emotion regulation between misophonia and other types of psychopathology? So in our funded study, we looked at 60 adults who either had clinical emotion dysregulation or misophonia. And they went through a phone screen and then an in-person screen where we did a clinical assessment and established them either as adults with psychopathology or adults with misophonia. And in the in-person screen, we also asked people to listen to 100 different sounds that are either neutral, aversive, pleasant, or potential misophonic triggers, with the idea that we wanted to identify a set of stimuli that are personalized, that are misophonic triggers for participants. Then the participants in the study had an imaging visit where we asked them to listen to those trigger sounds and either just listen or try to downregulate distress. And these were those personalized triggers that we had identified in the previous visit. And then we did an experimental visit where we tested several approaches to a possible future intervention in one experiment to see what would be the best approach to build an intervention for misophonia. So here's what we found. First, I thought it was interesting to kind of show you what happens in the brain when you present a trigger sound in misophonia versus in a clinical control. So this is an aggregated map. So all participants kind of put together. And what you can see is that in this figure over here, that's kind of like a slice through the center of the brain. If I would cut my brain through here, that's what you would see. There's a lot more activation when in response to triggers in this area over here when compared to controls. They don't have as much activation there. And that excessive activation is in that insula, in the insular cortex. And again, that's the region of the brain that's responsible for paying attention to your own body, your own sensations, processing emotional inputs, and so forth. Outside of that, there's a lot of similarities in how the brain reacts when someone with misophonia or a clinical control listens to a trigger sound. We also found some differences when we compared the two groups, specifically when we compared hearing misophonic sounds with aversive sounds that were non-misophonic. So again, just like I showed you visually in the previous figure, when we compared the groups, we found much higher activation in the insula in the misophonic group versus the emotion regulation group, highlighting that above and beyond what happens in clinical psychopathology, there is something about how the person integrates the sounds that they're hearing with their insular cortex that's higher in misophonia than is in any other group of people. Another thing that we found is that participants with misophonia had much higher activation in this area right here than the control group. So this area here is connected to the ventral attention system, which is a system that helps you pay attention to stimuli that you might have ignored otherwise. So let's say that there's something in the background. You know, we all kind of let go of everything that's around us, and there's something in the background, and finally we narrow our attention on it because it's becoming relevant. That's the region that seems to be more active in misophonia when we tell people to downregulate their distress. So what that tells me is that the approach, at least my participants with misophonia took to reducing their distress, was to really try to pay attention to something else that was not the triggers that they were listening. So last but not least, we did an experiment to look at building blocks for an intervention. And here's what we found. So if you look at this block over here, this is someone's reaction to a misophonic sound. And on the side, you see the scale of self-reported distress. So how stressful it was to listen to trigger sounds from 0, not distressing at all, to 9, the most distressing. So on average, participants with misophonia, when in the presence of trigger sounds, had pretty average distress. By comparison, the clinical controls when listening to misophonic triggers had much lower distress, which is what we expected. So then we tried all sorts of different things to see what would reduce that distress the most. Oops, there it is. So I'm going to put this line here as a way to see, to compare with the just listening to a sound. In one condition, we did neuromodulation that promoted regulation, that helped the regulation circuitry. And you can see that by doing that and nothing else, we already reduced the distress that misophonic participants experienced in a significant way. We also tried to do neuromodulation to inhibit reactivity to sounds. And by doing that, we again reduced distress in a significant way, but a little less than by promoting regulation. We also taught participants an emotion regulation skill, just like in cognitive behavioral therapy, and we had them practice that skill while listening to their trigger sounds. And you can see what a big effect that had, because we really dropped very significantly the amount of distress that people reported. And then we combined both interventions. We had participants engage in neuromodulation that promotes regulation while practicing emotion regulation. And that actually led to the most decrease in distress when compared to just listening to sounds. So to conclude, misophonia appears to be different than emotion dysregulation when examining brain responses. Insula circuitry seems to be critical in the understanding of misophonia. Cognitive skills training and neurostimulation can be promising for intervention, both individually, but their combination seems to be the most promising. And then promoting emotion regulation tends to be a more promising approach than inhibiting reactivity. And that is it. Any questions? Let me find you guys again.
Thank you so much. We have lots of questions.
Okay, great.
I've captured all that we have so far. So we'll start from the top. A lot of questions about the method itself. Can you talk about any side effects with neurostimulation?
Absolutely. So I can talk broadly and I can talk about the study specifically. So broadly, the worst possible side effect of neurostimulation is seizure, but it happens very rarely, 0.02% of cases in circumstances where the study is not really well controlled for safety parameters. But it's a possibility. In our study, nobody experienced that. What's more likely to happen with neurostimulation is discomfort at the site of neurostimulation, and about 30% of participants in the study experience some discomfort right where we put the coil to stimulate. I will tell you that discomfort was uncomfortable because they said it, but no one quit the study. So the 30 participants with misophonia and the 30 clinical controls that we had, no one quit the study because of that particular discomfort. So it was tolerable. And for the majority of people, it got better pretty quickly if they kind of stuck with it right at the beginning. Other potential side effects could be changes in mood, fainting. Some people faint. Again, we didn't have any fainting in the study. We didn't have any changes in mood, but they're possible. Some people report neck stiffness because we ask people to keep their heads still so we can target the same location for the duration of the intervention. So that leads to a little bit of stiffness. This is something that you can easily fix with over-the-counter Advil or Tylenol. Those are the big kind of categories of side effects that happen from neurostimulation.
So very interesting that nobody left the study.
That was one of my main questions, is like, are people willing to do this? Are people going to stick around? And no one left. So that gave me hope that we could try this out.
Does this mean that neurostimulation is a treatment for misophonia?
Not yet. So this was a translational study where we did a very tiny snippet of neurostimulation and a very tiny snippet of cognitive intervention, just to see what potential intervention did the participants respond better. What we need to do is a bigger study where we pick a specific intervention, and I would go for the combined approach and try it out for a couple of sessions and see long-term effects. We didn't measure the effect that this had outside of in the moment. Like, do participants feel better a week after, or do they respond less to their trigger sounds after they do this? We don't know any of those things. We just know that in the moment, when listening to a trigger sound, if you receive neurostimulation and you do a cognitive skill at the same time, your distress after that sound is significantly lower than if you just listen to the sound itself.
You partly answered this, but I want to make sure that it's very clear. Did you follow up with study participants sometime after the study? And if so, what were your findings? I think you said no.
We didn't.
Lasting effects of the intervention. If not, are there plans to do something like this in the future?
Would love to do that. So now we're in the phase where we're writing grants and trying to get more funding so we could actually do that follow-up study where we try a longer intervention. We try to look at follow-up effects. We try to do an intervention study, but we're not quite there yet.
Got it. Can you talk a little bit about how neurostimulation is a similar or different technique to neurofeedback?
Yes, very different. So neurofeedback is where you get direct information in real time from some physiological system. You can get neurofeedback from your brain, but more common, you get neurofeedback from your physiological arousal, like how sweaty your finger gets or your heart rate. And then you try to apply a strategy, just like we do cognitive restructuring in the study that I presented, and you get direct feedback how effective you are at calming down your physiology. And then you get better at that strategy because you see in real time kind of how to use it and in order for it to be effective. Neuromodulation or neurostimulation is where you're inducing electricity through a circuit in the brain. So you're like actively either promoting activation in a group of neurons or inhibiting activation in that group of neurons. So just very they sound the same, but they're very different approaches.
Maybe more related then, how is neurostimulation different or similar from ECT? So this stands for electroconvulsive therapy, which people may be more familiar with.
Yes. So they're same class. It's like using electricity to affect the brain, but very different interventions in the sense that one is invasive and one is non-invasive. So electroconvulsive shock therapy induces a seizure on purpose. You get as much stimulation as it's needed to have a seizure, a controlled seizure. And that's the mechanism through which that's thought to work is that you're kind of flooding the brain with neurotransmitters, and that can actually promote growth or new neurons developing in areas where they might be needed. Like neuromodulation, like transcranial magnetic stimulation or direct current stimulation, is where you apply a little bit of electricity to a very specific spot. You try really hard to not induce a seizure, so like direct opposite. And the mechanism through which we think it works is that you're promoting connection between neurons, not so much generation of new neurons in the brain.
We've got a few methodological questions. The first one is, how did you identify participants with misophonia? Did you use the Duke Misophonia questionnaire? There are a lot of different questionnaires.
Very many. So when we started 3 years ago, the kind of standard-ish at that point was the MQ, the Misophonia questionnaire. The Duke Misophonia questionnaire got published after we started. So we had people who were moderate to high on both of the subscales of the misophonia, of the MQ questionnaire. They had to score above 2.7 on both of those subscales and then over 7 on the severity subscale, which corresponds to moderate to high misophonia symptoms. The control participants could not have misophonia. So we tried really hard to make sure that those who were clinical controls would not be classified as having misophonia as well, to really have a good comparison.
Another method question: is neurostimulation treatment needed only once or multiple times? And related, in your study, what number of sessions are recommended and what was the duration of the sessions?
So in FDA-approved treatments, it's multiple sessions. Generally, it's about 20 sessions that happen once a day. So you would go in for 20 days of treatment. In the study that I did, we only did one session and compared multiple things within that session. So we did not do an intervention session by any means. I would assume for this to work, we would need to have a lot more practice within one session, and then we would have to have some multiple sessions to see effects that are longer lasting than in the moment. But we don't have those parameters yet.
We're at 10 minutes.
Thanks, Chris. Did your control group receive cognitive skills in the experiment as well, the cognitive reappraisal method?
Everybody, great question. So everyone was taught the cognitive skills. Everyone learned how to downregulate distress in the presence of upsetting sounds that were personalized to them.
Do you think it's more promising to promote regulation or to inhibit reactivity? And is it only possible to do that with neuromodulation, or can this be done using cognitive skills training or behavioral techniques or other methods?
Great question. So I was a little shocked. I thought we did this like very fancy method to inhibit reactivity where we kind of found the area that was connected to the insula and we like stimulated the circuit to like hit the insula directly. And I was convinced that all this like fancy stuff that I was doing was going to work the best. And it didn't. What worked better and significantly different in accordance to our results was to promote regulation, was to enhance the emotion regulation network. We used, the reason I kind of changed my title from Misophonia and Neuromodulation to Interventions for Misophonia is because even though I used neuromodulation in this experiment, by no means I don't think that the only way to promote regulation is through neuromodulation. Neuromodulation is just the tool that helps us kind of accelerate seeing the effects of promoting that network. So I could do it in an experimental way quickly, but I think you can promote regulation in all sorts of ways through therapy, through other means as well, not just by neuromodulation.
That's really fascinating. Could you talk a little bit more about what people think the mechanisms behind neuromodulation are?
So we think that what happens with excitatory neuromodulation, which is what the type of neuromodulation I use to promote regulation, is that you increase the long-term potentiation. So the learning between neurons to communicate with each other. It's kind of like you're enhancing connectivity. So it's kind of like we see hyperactivation in the brain in areas that are not tempered down by other areas in the brain, and neuromodulation is a way to increase connectivity between these regulation regions towards these areas that are overfiring in the presence of trigger sounds. I'm oversimplifying this, but hopefully that makes some sense of how we think this is working.
Can we talk a little bit more about the insula too? There's a question that because the insula is more internal to the surface of the brain, can it be targeted with neurostimulation? If it can't, what area do you recommend targeting, I presume, for misophonia?
So absolutely. So there is the kind of cutting edge neuromodulation right now is to do connectivity neuromodulation. So you identify more of a circuit rather than a region. So in the case of inhibiting reactivity for us, what we did is we identified the part of the insula that was most active in the presence of trigger sounds. And then we saw functionally what correlated with that insula at the surface of the brain. And we picked the medial prefrontal cortex for that. And then we targeted the medial prefrontal cortex with the idea that we're indirectly affecting the insula like that. And I'm not just saying this because I like hypothetically, there is evidence to show that if you target a region that's connected to another, you're actually affecting that other region as well. I don't know if I answer all the question about the insula, but I would go for the medial prefrontal cortex, and that would be the approach to it.
It's more accessible. Okay. I believe you answered this, but just to make it clear, when participants used an emotion regulation while exposed to a trigger, what skill or skills did they use?
We did cognitive restructuring. So specifically with regards to misophonia, I taught participants how to distance from the sounds, like break the sound into components, think about the pitch or intensity, or think about it as something that's very short-lived. I'm only going to listen to this for a little bit. It's not going to take over my entire day. Or think about what else could be making that sound. Is there a different, because it's just the sound, is there something else that could be producing that sound that's not the thing that's most obvious? We also taught participants reframing. So think in a way that's not catastrophizing. This is just the sound because someone might be like bored or not aware of what's happening. The worst thing that I'm thinking would happen is not going to happen right now. We spend like a whole hour trying to use cognitive restructuring and dissect it for misophonia specifically. And then that's what participants used in the experiment. I'm not doing it justice in like a couple of seconds.
We're at 5 minutes.
Thanks, Chris. Are there outcomes data with neurostimulation in OCD, and would these be transferable to misophonia? You mentioned FDA approval in a lot of conditions, but I don't believe you mentioned OCD.
So there is an FDA-approved treatment for OCD with neurostimulation. It's a different approach. Like there's a helmet, and they're targeting like a more inner structure of the brain, still in the medial prefrontal cortex. And there's good results with that. Absolutely. I think it would be a great idea to try the OCD FDA-approved treatment on misophonia and see if it works. I think there's some similarities between OCD and misophonia. I don't think misophonia is OCD. I think there's a lot of differences, but there are some potential common pathways in kind of neural deficits that we see between misophonia and OCD. That would be a great idea to try the treatment out. I'm biased. My approach would be to really understand misophonia from a neural perspective and then build a treatment based on that, rather than starting from another disorder and trying to adapt the treatment from that disorder to misophonia, because I think we can get to an intervention faster like that.
Well, thank you for sharing. I don't see any more questions coming in, but one more. Let's see. Did you find any connections to those with ADHD, prefrontal cortex being well established linked to ADHD?
So I think there's comorbidities between ADHD and misophonia, between ADHD and OCD, but none of these comorbidities are 100%. They're like 10%, 15%, 20%. And we can learn from these disorders what works for specific brain regions. So there's no FDA approved treatment with neuromodulation treatment for ADHD, but there's research for how to use neuromodulation with ADHD, and we can learn from that literature to see if we can find elements that could apply to misophonia. Again, my approach would be to stay away from other disorders and think about this problem separately and see if we can build something from the ground up for it. It's not at all wrong to go the other way around either.
There is a request to provide a reference for the FDA-approved neurostimulation for OCD. I'm going to suggest that question asker come to the next session, and where we're going to be having a discussion with everybody from the morning session about all kinds of things, including comorbidities and ways to address. Thank you so much. I really appreciate the time, Dr. Neacsiu.
Thank you, everyone. Those were great questions.
See everybody in the moderated panel discussion.
Bye.
Bye.